how you can access the site. So hopefully everybody's very happy that we record it and it's there for prosperity. So I'm delighted to welcome you all back after the summer break. I'm Sally Singh. I'm the Director of Training and Capacity Development for the BRC. And this is our break session where we're going to focus very specifically on the cardiovascular theme. So I'm delighted that Professor Jerry McCann is going to lead the session with his team. As usual, we'll have time at the end for questions, and today we're going to run through the 3 presentations, and then there'll be the opportunity for you to put questions in the chat or pop your hand up at the end of the session and ask the team any questions that are relevant to today's presentation. One thing that I need to remind you all of is that the BRC annual survey around capacity development and training is launched, and I hope that all of you that are on our BRC mailing list will get that survey later on today. And I really would encourage you all to complete the survey. It's really important to us as a training platform to understand what your needs are in terms of training, so we can provide that very specifically. And unless you tell us what you need, it's very difficult for us to second guess what that might be. So please rest assured that your information is really valuable to us, and hopefully in turn valuable to you to help fill any gaps with training or indeed any other areas that you identify in terms of your career development or exposure to research. So I would encourage all of you to fill out the survey, and if you're not on the mailing list, perhaps you'd like to get in touch with Harvey, because obviously the more data that we have, the more valuable and meaningful it is. So I'd like to thank you all in advance for helping us with that. But I'm now going to pass over to Jerry, who's going to kick off today's proceedings and then introduce our subsequent speakers as well. So thank you, Jerry.
Thanks, Sally. So I just moved my screen thing here. So I'm Jerry McCann. Sorry, I'm just struggling moving. Oh, there we go. So I'm Jerry McCann. I'm Professor of Cardiac Imaging and an Honorary Consultant Cardiologist from Cardiovascular Sciences, and I'm the current BRC Cardiovascular Theme Lead, and I also lead the intervention theme along with one of my co-speakers, Anvesha Singh. If there's anything I think I want you to take away from this, it's probably 2 things. One is that there's more than one way to succeed, and academic careers are not linear. And I'm going to show you that with my own journey. So let's see, slide hasn't moved. There we go. So I want to tell you about what's been happening to me, particularly over the last 20 years. And I obviously was looking for a word to rhyme with zero. So I've called this From Zero to Hero. Clearly, I don't think I'm a hero, but I am held up as, you know, a very successful academic, both within and out with the institution. And I've got, you know, lots of roles. So I was appointed in Leicester as a consultant cardiologist in 2005, and at that time I had a small clinical team and we had no research activity, no research staff. And this year I've been appointed as a senior investigator for the NIHR. I had a research professorship for the NIHR, got a big group of people working within the BRC as well as intervention theme lead. I've led national infrastructure and awards such as the BSMR research group, and our own cardiovascular imaging group comprises about 25 to 30 people depending on the number of number of students primarily. So how did I get to where I am today from that somewhat humble beginnings? So I'm going to take you right back. But before I do that, these are some of our world-class outputs that the Cardiovascular Imaging Group have taken part in. And you obviously don't succeed in these overnight, deciding I'm going to do research, and it has been a bit of a progressive journey. And my journey started, Hannah, did you have a question? Sorry, I just saw your hand up.
No, sorry, that was an error. Sorry, Jerry.
Okay, so this is where I grew up, and around the time that I grew up, and the picture on the left is actually diagonally opposite where I lived, and it's in Govanhill, which is in inner city Glasgow, and we lived on the first floor above shops just like this, and the corner of the house was our living room. We had a one-bedroom house, and I slept in a cupboard between the living room and the kitchen with my older brother, who was 9 years older than me. So it was even more crowded than Harry Potter because there was two of us in the cupboard. And we weren't in the stairs, but we were off the living room. So if we wanted to go to bed and someone was watching telly, or if my parents were having a drinking party, which was not infrequent, then I just had to sup it and see. And although our house, our tenement building we grew up in, wasn't a slum, round the corner, just here on the top right, is literally round the corner from where I grew up. And this is where quite a lot of it looked like. And that pub standing in isolation was my dad's local, the Govanhill Bar. And I didn't really realise we were poor. And in fact, I thought we were better off, because about a third of the people that I went to school with didn't have a toilet in their house. They shared it between 4 families. So that's the kind of environment I grew up in. And I'm the youngest of 5 children. I'm glad to say all my siblings are still alive. And my family were Irish immigrants. And in fact, all my siblings were born in Ireland. So I was the only one born in Glasgow. But from a very early age, the environment that I was in, both in the family and growing up in Govanhill, could be described as competitive. And I liked that. I really liked the competition. And I went to the largest school in the west of Scotland, a large comprehensive called Holyrood. And I did well at school. And I didn't get bullied too much, probably because I was good at sport. But, you know, it was a very mixed upbringing. And maybe because I was youngest, I was really desperate to go to university at a young age. And in Scotland, you could go after 5 years at secondary school. And I managed to do well at school, and I applied and somewhat surprisingly got in to medicine, and quickly joined the cross country, the Hares and Hounds, and the athletics club, because that was something I was really interested in. And after 2 years of medicine, I took 2 years out and did an intercalated BSc in physiology and sports science. And I didn't do that because I thought it would help my academic career, and I'll explain a bit more. But it did start my interest in physiology, and I was always interested in sport. And I was a bit of a mediocre medical student. You know, I passed everything. I do take some pride in that I didn't ruin my summer. So I had no resits. And that was the defining thing for me, was I didn't want resits. So I did enough to pass. But when I went back into medicine, I started performing a little bit better, probably because I was a little bit older, and also because doing the basic science subjects, that really wasn't why I did medicine. And actually, once I went into clinical and you got to speak to patients and understand their problems, that's where I started to do better. And I managed to get 1 distinction in my finals. That was the only significant award I got. So my undergraduate highlights really were much more around beer drinking. And that's me on the left with my slightly chubby cheeks, even though I was running at the time. It was probably puppy fat, actually. And more seriously, this was me in my prime as an athlete. I was a middle distance runner. And that was part of the reason why I did enough to pass. I trained at least 6 times a week. So it was probably, you know, in total spending 12 to 15 hours a week. And my ambition at the time, I did run for Scotland, but my ambition was to run in the Commonwealth Games. And to be frank, I mean, I didn't achieve it, and I wasn't actually that close. And part of that was the balance between doing medicine, running, and beer drinking. But the competitiveness was there. And later in my life, I have translated that competitiveness into my academic career. And the reason I'm showing you all of this is, I think you've got to understand yourself and what you do and what really motivates you. And I'll talk about that a little bit more. So I graduated in 92. My early postgraduate career went very smoothly. I just focused on getting my professional qualifications, and I managed to do that the first time. And that sort of started to put me on a slightly different path. But I wasn't quite sure which specialty to go for. So in 1995, I was keen to travel and I went to New Zealand. And I'd worked with a girl from New Zealand. I was going to go to Australia and she said, go to New Zealand, it's much better. And that's when I really started to do cardiology. It's when I got together with my wife, Kate. She chased me out there, but managed to get there before me, being devious, and made it look like I was chasing her. And I started playing football again, having stopped running. And I actually got offered a job. I came back slightly early from New Zealand. In fact, I really liked it. I would have stayed, but Kate thought it was too far away from home. So we came back, but I was offered a job as a research fellow and acting lecturer in cardiology and sports medicine. And my boss had just set up the first ever BSc in sport and exercise medicine at the University of Glasgow. So I took that on and I was coordinating the BSc. I was doing my research, which I made up my own project. I had soft funding. We were doing thrombolytic on-call trials. I was doing clinical cardiology for about 40% of my week. And my boss had about 6 jobs. And really, I learned how not to do research. And I really wanted to become a lecturer in cardiovascular and exercise medicine and training cardiology. And I hung on, and actually, it never happened. And I managed to write up my MD. I don't know how. Well, in fact, I do know how. My wife was studying for at the anaesthetic exam, and we just basically locked ourselves away. And importantly, I did have some presentations and big meetings, but I had no papers from my thesis. 0. One editorial that I wrote sometime afterwards. So just bear that in mind. So at that point, I was completely disillusioned with research in academia, and I thought I'd worked incredibly hard, and I saw people overtaking me, and I was like, I'm never going to do research ever again. And that's kind of where I was. So you've got to ask yourself, why are you doing research? It can be seen to strengthen your CV. You may want to be seen as an expert. You may want to get invited to conference. And if you're a clinical academic, there is one of the domains in the Clinical Excellence Awards, particularly about impact. But really what you should be asking yourself is, what is it you actually really want to achieve, and will it make you happy? Because if you follow that, then the chances are you'll enjoy it and you'll do well. So I'm going to talk a little bit about successes, but failures are just as important as the successes. And all of us have had many, many more failures than successes. To be a successful academic, you must get grants. And I'm going to show you some of the things that we've done, but you've got to walk before you can run. And then look at opportunities, collaborations. And I'm going to talk a little about people and leadership development, which has been particularly important to my career. And I'm not the same person I was 20 years ago, for sure. So my first research paper, so I did during my integrated BSc, I did a project where I designed individualized exercise tests on a treadmill for patients. And at the time, of course, I didn't know this, but Henry Dargy was a world leader in heart failure. Simon Ray, who's the first author of the paper, became president of the British Cardiovascular Society. Ian Ford was professor of biostatistics at the Glasgow Clinical Trials Unit. And John Norrie became director of the Edinburgh Clinical Trials Unit. So I didn't even know it, but I was in this world-class environment. And then I did another paper that was actually, we did with one of our BSc students, and that's the first one I actually wrote up. And I remember how long it took me and how hard it was, but it does get easier. I can promise you that. So I came to Leicester in 2000 to train in cardiology, and I had a year in Pilgrim. I then came to Glenfield in 2001, and that's where I really started to develop an interest in cardiac imaging, particularly echocardiography at that time. And it really complements physiology. And a career-defining moment for me was in 2004 when I chose and managed to get a bit of funding to go to Amsterdam to do a cardiac MRI fellowship. And that really is what's changed my academic career dramatically. And I came back to Leicester in 2005. I was initially appointed as a locum consultant and then a substantive. And Neelish Samani was head of the department at the time. And I said, you know, I really want to do academia again. I've been inspired. And he kind of laughed and said, your CV's rubbish. You know, had a few papers from Amsterdam, but I also had 3 children under the age of 2, and I was a new consultant, so it wasn't easy. But I couldn't stop thinking about research, and imagers are a bit like structural engineers or quantitative surveyors. Our job is to, you know, do an MOT to tell you whether your heart is tip-top shape, nothing wrong with it, or maybe you need a lick of paint, or actually the foundations are crumbling and we're going to send you to a surgeon. And one of the key things I do is try to stop people having unnecessary interventions. An MRI really was just 20 years ago was just really exploding clinically, and it continues to develop incredibly quickly, and it has this multi-parametric capability that allows you really to understand the structure and function and understand in vivo pathophysiology. And that's what really excited me about it and got me thinking about all the things we could do with MRI in terms of our clinical questions. So in 2007, we got to the point in April where I gave myself a bit of a talking to, because I was like, you say you want to do academia, but you haven't submitted any grants. And I had about 3 half-written grants, and then I decided I needed to focus on what I really knew. So my thesis was an exercise limitation aortic stenosis, and I basically took that and applied MRI, and I submitted my first grant on the 27th of April 2007 to the BHF as a project grant, and we went on holiday to Portugal the next day, and I forgot about it. And then the 3rd of May, everything changed because Madeline, our eldest child and daughter, was abducted while she was sleeping, and we were dining about 50 meters away with friends, and she's still not been found. So this is obviously a critical juncture, personally, emotionally, family, everything. Our world really collapsed, and you know, we stayed in Portugal for another 4 months. And we were accused by the Portuguese police of, you know, being involved in our own daughter's disappearance and all sorts of things. And at one point, you know, I actually thought we were going to go to jail in Portugal. And we decided we were definitely coming home at this point. And Kate had vowed she would never leave Portugal without Madeline. And we were coming back, and I was in the car on the way back from Lisbon, and Neelish phoned me to say, the BHF have offered you this grant. What do you want me to tell them? And I said, tell them to take it. So when I came back, I set up the grant. And that really, obviously, if I hadn't been offered the grant at that time, it's likely I would never have done research or done it to any great degree. So there are career-defining moments. It may not be as striking as this, but I also then, it changed my personality a little bit, where I was a bit more relaxed about some things, and it really made me focus on what I wanted to achieve. So after that, we got another BHF grant with Ian Squire. Then we got awarded a research scanner after the first BRU. I was bought out of clinical duties for 6 months, and I wrote 2 grants which were then funded. And then we've had a whole series of grants getting bigger, fellowships, 2 fellowships, another MR scanner, fellowships for people in the team, including Anvesha, who's going to speak after me, Ranjit. And then I got an NIHR research grant, took on the BRC, etc. And the whole thing has snowballed. But along the way, there have been lots and lots of rejections. So the first failure was I left Glasgow. I didn't want to leave Glasgow. I couldn't even get a job as a cardiology trainee in Scotland. I wasn't even shortlisted for Edinburgh. And then when I came here and I started doing a little bit, Neilish told me to apply for New Blood senior lecturers, twice got rejected. And my first postdoctoral fellowship, I wasn't even shortlisted for interview, although I got it the next year. So these are massive rejections at that time. So you have to have a degree of resilience and want to keep going. Other things that I've done, which I think has improved me as a leader and hopefully as a researcher, and certainly in the dynamics, is the NIHR leadership course. And this is something I've really taken on board. And as we build the group and the dynamics become very important, and I've do a lot of mentoring and action learning groups, and I've done subsequent leadership courses. So, and I don't consider myself the finished article. I'm always looking to improve and how I work and work with other people. Collaborators are really important. And obviously, as you get more senior, you will have more. And if you're junior and you're doing a PhD, you probably don't want many or more than one or two, because you've got to deliver what you do. But I took opportunity. There were lots of established researchers in Leicester, and we're in a world-class environment. And again, I don't think I realised how lucky I came from Glasgow when that was there. It never occurred to me ever that I couldn't lead an international trial or do world-class research, because I was working with people, and we're going to have two people from, again, different backgrounds who are going to show you the kind of work they're doing. And then the other thing that I've done is surrounded myself with really good people who made me look incredibly good, and they continue to do that. So when you're more senior, then, you know, choose people carefully. When you're more junior, choose your supervisor carefully. And that's probably it's pretty sage advice. So these are just 5 of the people who are here: Ranjit Arnold, Mike Graham-Brown, and Vesha Singh, who's going to speak, Emer, who's our postdoc, and Gaurav, who's lecturer in the department, who really have done amazing things working with me and in their own right. And, you know, these are a list of people who've come through my group over the last 20 years, and apologies if I missed anyone, because I did update it. But, you know, as you get bigger, working with people becomes more and more important. Also, you know, I talked about this in terms of why you're doing it. You know, ultimately, research is a job. We may feel passionate about it, but, you know, you've got to prioritize where it fits. And for me, family is my priority. And, you know, Madeline's still missing, but we had twins who are now 20. So we've got to look after your family, you've got to look after yourself, and you've got to look after each other. And whatever that is for you, make sure you make time for it. And the other thing is, we've had a huge amount of fun along this journey. And if you enjoy yourself, what you're doing, and you're passionate about it, and you're still trying to answer the questions, I couldn't stop myself thinking about research when I was a full-time clinician. But if you have fun and you enjoy yourself, then you're probably going to be successful. And a big part of what we do every 6 months is make sure we have an away day, and we get away from work, and then we usually finish with pizza and a few drinks. And I'll stop there. So we're going to move on to Dr. Anvesha Singh, who I've already mentioned a couple of times, and is an associate professor in the department and an NIHR Advanced Fellow, and she's going to tell you a bit about her journey.
Hi, sorry, I'm just trying to move. So can everybody see the slides okay? Yeah, okay. So thank you, thanks, Jerry. So I've only got 10 minutes, you'll be glad to know, so I won't speak for too long. So just very briefly to introduce myself, I'm an associate professor and excuse me, honorary consultant cardiologist. And I know this is an old picture because we're no longer a department, but that's all I had. My current role is 70% clinical research and 30% clinical, and I'm an imaging specialist as well. So I do cardiac MRI, TOE, and a general cardiology clinic. And in terms of my academic role, like many of you on the call, it's split between doing the research that we all do, which is running the studies, collaborator meetings and conferences, But in addition, supervising different types of students. So I currently have 5 PhD students, but 2 of them have got their Viva this month, so that'll go down. And I've also supervised intercalated medical students, ACFs and ACLs over the time. And then the other roles that I currently have, within the university, I am the Director of Clinical Academic Training. So I look after all the ACFs and ACLs. I'm part of the EDI committee, and I'm the imaging sub-theme lead within the cardiovascular BRC. More broadly, I'm also co-investigating the iReach project, which some of you may have heard about. And externally, I'm the chair of the BSCMR research group. So just like Jerry's journey, I guess I thought I'd tell you how I got to that position. So I was born in a place called Patna in India, which is shown in that yellow dot over there. And I moved to the UK at the age of 12. And these 4 images show the different secondary schools that I attended through my time. So the top left is the one in India where I started. And then the bottom left is the one in Peterborough. Then the top right is in Grantham, where I did my GCSEs, and the claim to fame is that Margaret Thatcher went to that school, apparently. And then I did my A-levels in Aberystwyth in Wales. Following this, I then went to Cardiff University to study medicine. And that's the beautiful image that they use, of course, on their website, but the actual medical school is the one shown here, which was just to the left of that beautiful building. But I think that's true for every university. So how did I end up in clinical academia? So I would definitely consider myself a bit of an accidental academic. I was not really intending to become one. I didn't really know what one was throughout medical school, to be honest. So when I finished medicine in 2005, after 2 years of initial training, I moved to the East Midlands to do my core medical training. And to my surprise and delight, I got a cardiology national training number in 2009. And that was definitely the first sort of big point in my career when I got the specialty I was really passionate about. But what you'll notice is there's no mention of research at all. I had not done an intercalated. I don't think ACFs existed at the time. So I had no research experience at all. And I think I had 1 case report in a non-PubMed index journal at the time I got a cardiology registrar job. But it was really in around 2011, 2012, I started to look around for opportunities. And in all honesty, it was because in cardiology, everybody did research. So I just wanted to tick the box. But I was lucky enough to get a PhD position with Jerry as my supervisor. And I think that was definitely a big career turning point for me as well. So after 3 years of doing my research, 2016 came, which was a particularly busy year. I went back to clinical training. I had my exam to do, all the competencies to sign off, and then there's nothing like a deadline to get you to write a thesis. So as you can see from the dates there, I just about managed to meet that deadline by about 5 days. And then I had my Viva as well. And again, at this point, I started to think about next steps, and I only had about just over a year, maybe a year and a half of training left, so I could have finished that and gone to become an NHS consultant without problem. But part of me was always wondering, what if, how far could I go in research? So there was clearly something in me that wanted to try a bit longer. And at this point, I got an email from Jerry to say there's an ACL post being advertised and I should apply. So I looked back and I thought, okay, well, my PhD journey was actually a lot more fun and a lot more successful than I had anticipated, thanks to the great supervision and team that I worked with. And I'd managed to have quite a few publications, and I also had won a national and an international Young Investigator Award. So I thought, well, I've got nothing to lose, why not apply? So I did. And I got the position of an academic clinical lecturer. And for those who don't know, what this does is it's fully funded by NIHR, and it gives you 50% protected time to develop yourself as a researcher. What it means is your clinical training gets prolonged. So I had about a year and a bit left, so this became closer to 2 years. So on the left, you can see all of the clinical competencies that I needed and all the accreditations that I needed to get my CCT, which I carried on. But on the right, it shows you the opportunity that being a lecturer can open up. So it really gives you time to focus on what you want to focus on and start to develop your own ideas rather than doing a predefined PhD. So I used this time to publish everything I could, including editorials, review articles, and original research. I went to lots more international conferences, had a great time sharing my research and learning about others. And then I started supervising my first PhD student, which again was quite a big change from being one myself. And the rest of the time, of course, writing is the most important advice I give to people who are at this stage. The more you write, the better you get. And of course, as Jerry's already mentioned, there will be failures, and of course there were. But eventually, I managed to get a small grant as a PI, and this was again quite a confidence boost for me to think, okay, well, I could write grants myself and get some funding. So I finished my lectureship, got my CCT and my current job, and then I was successful in getting an NIHR Advanced Fellowship soon after that, which is currently what funds my salary. But of course, it's important to remember that life carries on in the background as well. So as well as having 2 house moves, getting married, having my daughter, and this is just a recent big renovation project that we've had, which is thankfully finished now. So that was a bit about me, and I'll just briefly tell you a little bit about my research and then about some of the people that I've been working with, which has been really important. So my area of interest is aortic stenosis, which is a narrowing of the aortic valve, and this causes changes within the heart muscle as well as the valve and leads to changes. And MRI has been really important in trying to understand these changes and define when things start to become progressive and cause symptoms. And my specific research project was on a technique called myocardial perfusion reserve. And the first project grant that Jerry mentioned was conducted by Chris Stedman, who was my predecessor, who showed for the first time this new measure on MRI, which is the ability to increase the blood flow to the heart muscle during exercise, is actually associated with exercise capacity in people with severe aortic stenosis. So as part of my study, I looked at people at an earlier stage of disease and also showed that even before you get symptoms, this measure is already impaired and can also be associated with symptom onset in the future. So this is the first time this had been shown. But aortic stenosis is a really interesting condition because it develops very, very slowly over time. And who gets it and how quickly it progresses is extremely variable, and that's what makes it really interesting. And the other problem with this here is that at the moment, the only treatment is you wait till all the valve becomes very severe, people get symptoms, all the changes are happening in the heart as you saw, and only then do you offer them treatment. So there's a huge area of research that is needed to try and better understand the disease early on and try and work out if there's ways we can actually slow down the progression of disease. So that's really what my area of research has focused on over the years. So all the way starting from the epidemiology of aortic stenosis, trying to understand who gets it and who's being treated for it. We've done some work along with Sadia, who was a research fellow before, and published that data quite recently. And Harini, who's one of my current PhD fellows, who's a GP, she's doing a mixed method study, and we're looking at trying to understand perceptions of breathlessness, because in order to be diagnosed, people have to present to the healthcare professional in the first place. So we're trying to understand if there's differences in the way people present and how that might impact diagnosis and treatment. In addition, I'm also involved in some discovery work, and I'm co-supervising Molly, who's looking at some really exciting new targets to understand how we can slow down fibrosis and progression of the valve disease in the first place. And through a BHF project grant, we're also utilizing some of my samples from my PhD to look at proteomics biomarkers to better risk stratify people with aortic stenosis. And finally, of course, in order to get the treatments to patients, we have to conduct trials. And I'm involved in several trials as the local PI, including some industry trials, as well as NIHR funded one, and EasyAS, which is the largest randomized trial led by Jerry, where we're trying to find out the best timing and new treatments for aortic stenosis. And Ron is our current research fellow who's involved in recruiting for all of these. So I think I am just on time, so I'll just finish by saying, I think similar to, I suppose, what Jerry said, that it's not really about the destination. You may not know where you're going to end up, but I think what I've learned is you should enjoy the journey and take opportunities as they come. And then I think my biggest tips will be to surround yourself with good people and your network. So I was lucky enough to have a great peer support during my PhD. These are the other people I did my PhD with, and there's Jerry looking a lot younger. And then professional networks. So I've also attended some great leadership courses, and this was one organized by the British Cardiovascular Society. And we're still in touch, and every BCS we try to have dinner, and there's a WhatsApp group which is there for any advice needed for anybody across the country, and personal networks. So these are some of my close friends who all happen to be cardiologists and women, and this is the cake they got me for my 40th, so they know me very well. And then the other thing is really about seeing changes over time. So this is me presenting my own first ever poster in an international conference. And these are two of my PhD students presenting at the Young Investigator or Best of Best abstract session. So it's a huge satisfaction to see your role in how people develop over time. And finally, the position I'm in gives me the opportunity to make a difference in other ways. So through the university, I've involved myself with things that I'm passionate about, such as the iReach project, which is really about improving research culture, not just in cardiovascular medicine, but in the university as a whole. And of course, teamwork does make the dream work. So as Jerry has said, we're very lucky to have a great team, and that certainly has helped our group grow. Thank you. I think it's Shirley next, so I will stop sharing and I'll hand over to Shirley.
Hi everyone. Can you see my screen?
Yeah,
Yes.
that's good.
Okay, fantastic. Just put it on slide.
Just disappeared again, Shirley.
Is this okay now?
No,
I
we've
can't.
lost it again. We saw
Okay.
it and then it disappeared.
Oh, right. Okay. Can you see this?
Yeah.
We've got it. It's just not on full screen, Shirley. So I don't know
Okay.
if you can.
Yeah, I will try to make it full screen now. Can you see that?
Perfect.
Fantastic. So my name is Shirley C. I've just finished the academic clinical lecturer position. So I'm quite a bit more junior than Anne and Jerry. But I'm very glad to be invited to share my journey as well. So I started off sort of doing some basic science research when I was in medical school, just trying to get a sense of what research is like. And then I found that clinical research probably suits me a bit better. So when I started foundation training, I started looking at the gaps in research that are around me. So the idea of looking at frailty and older people with cardiovascular diseases started during my acute medical rotation, actually, as a foundation year 1 doctor. I was observing that a lot of patients who are admitted to hospital in the acute medical unit are actually older people with different cardiovascular conditions. And when you look at the guidelines, a lot of the clinical trials out there were focused on much younger patients, and whether those guidelines and those trial results are applicable to older people with cardiovascular conditions are unknown. So I started looking specifically into heart failure and frailty related comorbidities, which are more prevalent in older people with heart failure. And that's when I started with sort of exploring this research topic. So as part of my MD, which I did following my foundation year 2 program in the academic foundation pathway, I obtained a scholarship from the University of York, and then I started doing this MD work. It was a bit difficult at the time because it wasn't a research topic that was very popular, and it was a new research idea that I brought to the team at the time. So it took a lot of convincing before I can convince my supervisor and the rest of the team to look into this topic a bit more. But I started doing the work anyways because I felt like it has a great clinical impact. So the first bit of work that I did in my MD is to look at different populations of patients with heart failure and try and understand the prevalence of frailty and how frailty relates to clinical outcomes, and that would include death and hospitalization. So you can see that in the bar chart on the left, I used different frailty assessments to quantify the prevalence of frailty. And you can see in the bars in black that almost half of the patients with heart failure are actually classified as frail. And on the right, this is frailty assessed by the clinical frailty scale, which is used a lot in clinical practice these days. And the more frail you are, which is shown in the red line there, the higher your mortality rate and hospitalization rate. Then I try to understand why patients with heart failure and frailty keeps coming back to hospital. Is it related to the medication we treat them with, or is it because they are admitted with other causes other than heart failure? So I looked into the cause of death and hospitalization in patients with heart failure and frailty. And you can see that in the bars represented in blue, they are non-cardiovascular causes of death and hospitalization. In contrary to what most cardiologists think, actually a lot of heart failure patients with frailty are admitted with non-cardiovascular causes. So even if we optimize the patients on heart failure therapy, there is a significant proportion of patients who are admitted because of non-cardiovascular causes. And mainly from the results of my study, it's because of recurrent infections, recurrent falls, mobility issues, care issues. And then I went to look into how different frailty phenotypes present in patients. Patients can be frail because of lots of different reasons. It could be related to comorbidity burden. It could be because of physical deconditioning. It could be related to cognitive impairment or social isolation. So I looked at different types of frailty deficits and see how these frailty deficits overlap with each other in my cohort of heart failure patients. And you can see that the majority of patients have more than one frailty deficit, so they definitely coexist. In the Venn diagram, you can see how they overlap with each other. And about 8% of patients have all 4 frailty deficits. And I also found that the more frailty deficits you have, the more likely you're going to suffer from adverse outcomes, including death and hospitalization. And each of these frailty deficits are related to poor outcomes. So all of these are very important in terms of managing patients with heart failure and frailty. So with these few ideas in mind, I went on to sort of further develop this research topic by looking into developing a holistic and individualized intervention, hoping to improve their physical functioning, their quality of life, and to reduce hospital admission in older patients with frailty and heart failure. And I started looking into this during my ACF post in Leicester. As part of the ACF, obviously I finished my MD writing up, but I also used the time to develop a grant application to look into developing this intervention. And I was very lucky to be successful in obtaining my first personal grant as a principal investigator leading this trial. Initially, it was just a trial on to be conducted in Leicester, but then BHF offered me more money to expand this into a multi-center trial. So I'm now doing this intervention in 2 different hospital trusts to assess its sustainability and generalizability across different healthcare settings. So just a bit about the trial. So we have 3 stages here. Stage 1 will be trying to map out the existing heart failure pathways and see what gaps there are in the pathway. We'll be interviewing patients, doing surveys to understand from different perspectives, from patients, carers and healthcare professionals' perspective, what's missing in the current healthcare for older people with heart failure, and what are their actual healthcare needs. And in stage 2, we wanted to try and co-produce an intervention with the different stakeholder groups. The idea is to develop something that's holistic and suitable for the patients. And the 3rd stage is to trial the intervention, both assessing its feasibility, its efficacy, and also looking at the process to see how we can improve the delivery of such complex intervention. In stage 2, we also carried out a sort of a side study to look at the activity level of patients with heart failure and frailty, because from clinical practice, when we see them in clinics, a lot of them even struggle to walk for a few steps. And that's why a lot of patients with heart failure were automatically not recruited into the physical rehab programs that we have. And because of their comorbidity burden, a lot of them were deemed not fit for the program. So we wanted to develop something that's individualized and suitable for this group of patients. And by wearing a wrist accelerometer, we would want to understand their activity profile and try and incorporate those findings into delivering an exercise program that's suitable for these patients. So in stage 1, we identified 7 main key areas where we think we want to work on in this trial. The first one is medical issues, mainly poorly controlled comorbidities other than heart failure, and these include incontinence, falls, cognitive and mood disturbances, which are very common actually in heart failure patients, but are often neglected in our clinical interaction with patients. Medication, looking at polypharmacy and non-adherence mainly. Physical functioning, it's to work on strength and balance issues to minimize falls. Activities of daily living is to support patients to carry out their normal activities at home. Environmental and social support, any home adaptation or anything that could promote independent living. We would like to address as well. Nutrition is a very important aspect of the care of older people with heart failure, mainly addressing poor appetite, lack of protein intake related to sarcopenia, which could in turn relate to poor mobility. And last but not least, the access to healthcare. A lot of patients said it was really difficult for them to access even primary care to discuss their health issues. So through this intervention, we hope to provide a pathway for easy access for patients for any healthcare issue. In order to develop such a complex intervention to address the different healthcare needs, we needed a multidisciplinary team. So we've been working with UHL to try and put together a multidisciplinary team involving heart failure specialist, a geriatrician, pharmacist, dietitian, occupational therapist, and a physiotherapist. The idea is to provide a holistic pathway addressing the different components of care that patients require. So this is some sort of very brief results of our stage 2A sub-study looking at the activity level of patients assessed using the wrist accelerometer. you can see that as the frailty status worsens, so does the volume of physical activity, which is expected. But the very interesting finding is that even non-frail patients who have heart failure, a lot of patients spend quite a bit of time during the 24 hours in the inactive period, and to be involved with light and moderate to vigorous physical activity. That is, it's quite rare. And obviously, the more frail you are, the less likely you are to engage in the more intense exercise or activities. So then we move on to the co-production process. We involved obviously the healthcare professionals, older patients with heart failure and frailty, and also their carers. We sit together and we conducted several focus groups to determine each component of the complex intervention. And we went through a series of refinement, rediscussion, perfecting the intervention before sort of developing a final version of the intervention with an implementation guide. After that, we also discussed our intervention with the specialised clinical frailty network in the NHS to obtain any further advice or suggestions for improvement before trialling it. So this is our 12-week program. We started off with a baseline visit where we do a comprehensive assessment, including physical assessment, clinical assessment, your frailty assessments, and most importantly, we ask patients what they want to achieve in the next 12 weeks. We create an MDT checklist. The MDT checklist is to guide the MDT discussion, where our MDT group will meet once every week. During the MDT, we will come up with an individualized care plan for each patient, depending on their care need. And we've organized a one-stop clinic where patients will be have the time and space to interact with the healthcare professionals that they need to see in the MDT. And the intervention, which will be individualized to the patient, will be delivered in the same setting. After that, we've created an interactive portal where the healthcare professionals can create clinic letters to the GP to communicate what they've done during that one-stop clinic, and to suggest any follow-up if necessary. And after every 2 weeks, we will have a follow-up by the key worker or the healthcare professionals, depending on what the patient requires, to address any concerns or to up-titrate the exercise program if necessary. And by 12 weeks, we would like to see if there's any improvement, mainly in quality of life, physical functioning, that they are our main key outcomes. So, for example, the exercise program, just to show what exercise program we've been doing, we discuss about focusing on resistance training and balance, because that's what matters most for the patients. We incorporate a lot of activities that will promote activities of daily living delivery in the exercise program. We do it about 3 sessions per week, and if the patient can sort of tolerate it, it could be increased more. And it's a progressive exercise program based on the Borg scale. The exercises will be up titrated, and if patients can sort of work with resistance and balance exercise, they can be moved or added to aerobic exercises as well. So we've created a booklet to illustrate the exercises with a QR code, so patients can look at videos that we've recorded for each specific exercise. For example, for nutrition, we emphasize a lot on adequate protein intake, and the dietitian took the time to create personalized meal plans for patients. We have some sort of advice and suggestions about what symptoms to look out for and when to contact healthcare professionals, how to manage incontinence, which is a very common comorbidity, and a list of medications so patients would be clear about which one to take, and if there's any changes that we need to do, it will be all documented in the booklet as well. Some useful contacts for patients. So we are currently sort of finishing the Leicester site follow-up. We're waiting for the second site to finish their follow-up data, and we'll be looking at the process evaluation as well. But here are some of the other work that I wanted to do or have been involved in during the process of my ACL, to look more at sarcopenia, working with Jerry and the imaging group, using CMR and muscle energetics and muscle biopsy results to quantify sarcopenia in this group, working with Claire Lawson to use bigger registry data.
Shirley,
Yeah.
I think just in the interest of time, we
Oh,
should
sorry.
probably stop there,
Yeah,
because I think
sure.
the idea was we give some people
Yeah.
opportunity to
Yeah, sure.
ask questions. There is only a few minutes left, but thank you. It's the
Thank
first
you.
time I've seen that completely, so it looks fantastic. Thank you.
Great.
It's been great, and it's been great to have such a diversity of career trajectories with all sorts of challenges along the way. So thank you to all three of you for doing that. And I'm very happy to take a few questions if anybody has them. Nobody's path seems to have been particularly smooth for any of these sessions, and I think people really appreciate the honesty that people share on their slides. So thank you for that. I think teamwork and surrounding yourself by supervisors that are going to support you well is critically important. And getting used to failure, I think, is key. The sort of often undisclosed part of research, isn't it? But it's that is all part of the journey. And I take your point about learning to write as well. I think that's a hidden art that perhaps we don't expose ourselves to or have training in as perhaps much as we should. And I think from a BRC training platform, and that's something we've been looking at as well, to help people develop their writing skills, be it for a thesis or a grant.
Yeah, I think that's such a critical component, Sally, and I think, you know, you and I, and we've supervised lots of people, and if students can get a good introduction to you in a reasonable time frame, you know that it's going to go pretty smoothly.
Yeah.
And almost everyone who's struggled, you're chasing, and so forcing yourself to write. I don't really know many people who actually enjoy writing.
Okay.
Despite it being such a big component of what we have to do, but there is that element of having to force yourself to do it.
Yeah,
That's probably why we need those deadlines.
Absolutely. I have every diversion strategy under the sun not to write. So I think even when you become fairly senior, it is not the most joyous part of the job, is it? It's a challenge. And if you're naturally a good writer, I think that is such a gift. I'm afraid there's 4 pages of people. I can't see anybody with their hands up. I guess, Shirley, I'm going to take, chair's privilege again and ask you, to a certain extent, with one of my research interest hat-ons, and I'm sure Jerry's, is that what you've described as an intervention would probably work for every disease that people have an interest in on this call. So in terms of next steps, I guess my challenge is how do we how do we look at interventions that have worked in one disease and then test them in other diseases? Or perhaps we don't, you know, the challenge might be, do we make an assumption that they're going to work in other diseases that display the same symptom burden?
That's a very, very, very good question. And you know, the patients that I've seen with heart failure, a lot of the time they have kidney problems, they have respiratory problems, and I don't see why we have to. The reason I focus on heart failure is because I'm a cardiologist and my specialty is heart failure. But I think we have to use a less siloed approach. We should be looking at the person as a whole person. It may just be long-term conditions rather than a complex intervention for people with long-term conditions rather than a specific disease. As you point out very rightly, that a lot of these patients will benefit from a holistic individualized care approach. And yeah, I'm in this group of patients, I'd say a lot of the time we're actually communicating with other specialists to look at other medical conditions rather than just the heart failure. So I think that approach will be a way to go in the future.
Jerry?
No, I think it's a great point, Sally, and Priscilla, and I was just thinking, you know, and part of what we're doing in the stage B heart failure with multiple long-term conditions, really thinking about basket trial. And you know, we could put lots of disease in. It's certainly something for us to think about in terms of the next BRC. And one of the things that was commended at the CRE external scientific advisory group yesterday was the focus on multimorbidity. So that's a really good point, and we need to get away from what Shirley did, which is take these younger heart failure patients who aren't representative of the population.
No, you know, we as you know, we have a programme grant looking at multimorbidity and a very similar intervention, Shirley, albeit arguably at a slightly earlier stage. But you know, I would suspect that you could cross out heart failure on your slides and put it for, like you say, COPD, you know, renal, almost any other disease. So it's a real challenge, isn't it, Jerry? And I think that moving forwards with the BRC to have a more joined up sort of multimorbid approach where we know interventions have worked in single index conditions to explore a more holistic sort of disease agnostic approach.
Yeah, and I was thinking, you know, and I noticed you had a process evaluation built in, because as you're describing, it clearly is a very complex intervention, because you're looking, when you say holistic, there are multiple aspects and which bits of it work. But it's a great study.
These interventions become very black boxy in a way that you just don't quite know which intervention, or is it the sum of the parts that has added value. But to absolutely personalize an intervention to win an inch of its life is quite challenging in this population, I think. Really interesting session. I think there's lots of discussion there and thought-provoking ideas that will hopefully help all of you on the call today, certainly help us formulate some ideas for the next BRC. And I think Jerry helps this idea of cross-collaboration between themes as well, which I think is something that, you know, the BRC is very keen for us all to do. So hopefully you've got a real feel for what's going on in the theme, people's journeys, which I think has been the most inspirational part of these break sessions, which I think certainly caught me by surprise. But, you know, most of the comments have been thanking people for their honesty and describing their journey. So I'd extend that thanks to the three of you again today, and remind you that we have a special edition break session on Thursday, which is all around women's health. And you're going to have to remind me, Harvey, what time it is, because I wrote it down, but I've scribbled so much else during the meeting.
It's at 1 o'clock tomorrow, between 1 and 2.
1 o'clock tomorrow. So hopefully you'll all be able to join us again for a special edition break. So to complement the very successful sessions that we've had already. So thank you all for joining today. I'm just going to do another plug for the BRC survey, so please do look out for that email. And also there will be QRS codes dotted around the hospital on various flyers and notice boards, so please look out for those and share with your colleague, and look forward to all of your responses. So thanks again, Jerry, for leading this, and to Anvisha and Shirley as well. So great session. Thank you.
Thank you.
Bye.